Hi guys, this week's mini lecture is talking about some care of the normal newborn. So this is going to focus more on medications, procedures, screenings, the things that we are either the nurse is responsible for completing or responsible for making sure gets completed outside of our normal assessment and intervention on assessment pieces. So to start off with, let's go over some common medications that we offer or administer to all newborns. So starting with our vitamin K. As we discussed, the infant's gut is sterile and vitamin K is produced within the gut. Vitamin K is responsible for clotting factors. So without this in the body, the infant is at an increased risk for hemorrhagic disease in various forms, increased risk for bleeding. So vitamin K is administered usually within the first hour of birth. It doesn't have to be like as soon as baby comes out, but it is a priority. Once baby is born, it's given intramuscularly. It's given in the vastus lateralis, the baby's thigh. This one dose prevents all of these increased bleeding problems for baby. So some you'll hear OB nurses give in report, they'll be like, baby got shots and drops or eyes and thighs are done. This is referring to, so the vitamin K is the shot or the thigh part of those shorthand terms. The eyes or drops part is erythromycin. So this is an ointment we put on the eyes. It prevents infection that can cause blindness in babies. There are a handful of different bacteria and viruses that can cause blindness. So we know that by doing this prophylactic treatment, we decrease the risk of those complications very greatly. So this is also given within the first hour or so. It can cause slight inflammation of the baby's eye and surrounding tissue. There might be a little bit of clear drainage that we can just wipe away. There is kind of some push in the more natural birthing environments to use colostrum instead of erythromycin on the baby's eyes. If the mom can express colostrum, some will choose to do that. There are some studies that show just as much support for that as the erythromycin, and there are some that have kind of debunked that efficacy. So standard practice is still erythromycin ointment, but you might see moms choose to go the more natural route with colostrum, trying to get to the same goal. We move on to hepatitis B. So this is the only immunization we offer to newborns right after birth. Typically, so if mom is hepatitis B negative, and that is a lab that we would screen in pregnancy routinely. So as long as mom has had some adequate prenatal care, we would have her hepatitis B status when she comes in to deliver. If mom's hepatitis B negative, we give the first dose of the 3 series hepatitis B immunization. They get it at birth, they get it at 2 months, and at 6 months of age, routinely. Parents can refuse hepatitis B immunization. They sign a refuse to consent. Some do that because they don't want to vaccinate at all. Some would just prefer to wait until they go for their follow-up to their pediatrician and start the series then. That is well within their right. If we are giving the hepatitis B immunization, we chart the lot number and site given on the infant's chart. This is an IM administration, also in the vastus lateralis, whereas we usually use for IM administrations in babies, same as that vitamin K injection we talked about. Where we get into higher risk category and different treatment is if mom is hepatitis B positive. This changes our plan of care for baby. Not only does baby need to receive the hepatitis B immunization at birth, baby also needs to receive hepatitis B immunoglobulin, or HBIG. This protects baby from contracting hepatitis B from mom. And then we've already also started that immunization series. Hepatitis B is a reportable communicable disease. So if mom is hepatitis B positive and we have to treat baby because mom is hep B positive, there is state reporting and there's some extra paperwork that goes along with that. And you would just follow the hospital policy for those pieces. But if mom is hepatitis B positive, that changes our plan of care for baby. A couple other medications that you'll see commonly used, lidocaine is used to infiltrate, create a penile block for circumcisions. So that is a local injection anesthetic that is performed by the physician that is doing the circumcision. Sweeties is the sugar water, like sucrose solution that we will dip pacifiers into to stimulate sucking reflex for calming. This is only used during painful procedures. So circumcision, blood draws, IV sticks, those kinds of procedures. We don't use sweeties just so that baby will stop crying or so that we can get our assessment done or pieces like that. This is, saved for painful procedures only. I know in practice you might see otherwise, but that's typically standard policy for agencies. Switching gears to some common screenings we do for babies. So critical congenital heart disease, or CCHD, affects 8 to 12 per 1,000 live births. We see different signs and symptoms depending on what the congenital malformation is. Very commonly, we see cyanosis in the infant, detectable murmurs, tachycardia, tachypnea, diaphoresis, a lot of other very serious issues. The problem with these is most of these don't manifest until the baby's a couple weeks old. So, and again, we talked about how those normal newborn adaptation pieces that we might hear a murmur within the first 24 hours of baby's life because of those changes occurring. So again, we document that we hear a murmur, but every time we hear a murmur, we don't automatically assume, oh, baby has some kind of heart abnormality. So again, those signs and symptoms don't manifest until usually after baby's out of our care. You have listed there some of the most common congenital heart diseases. I am not going to make you memorize that list. You will learn more about them and more in depth in pediatrics. But what I do need you to know is how we perform this screening and why we do it. So the CCHD screening is universal. We do this on all infants. It's very non-invasive, very cost-effective, very simple to do. This is usually completed by the RN, or in some agencies, the respiratory therapist will complete these. We wait until after baby is 24 hours to complete this screening. We do that so that we don't get false positives because of those underlying newborn changes that are happening to the heart, the closure of the PDA, the closure of the ductus venosus, the closure of the ductus arteriosus. So if we do this screening before 24 hours and those haven't fully closed, we run the risk of picking up a false positive just because baby's too young. So after 24 hours of age, we complete the screening with a pulse oximeter, and it's as simple as that. We do the right hand, always the right hand, if that's our preductal reading. So if you think about the circulatory system and the way that goes around the body, the blood coming from the right extremity is right before that blood is passed through the heart and lungs. So we do the right hand first, we get a reading for that, and then we do either foot, postductal, after it's been oxygenated and sent through the body. The baby passes the screening if both of those readings are above 95% and less than 3 percentage points different from each other. So if my preductal right hand reading is 98% and my left foot reading is 96%, those are both above 95, and those are within 3 percentage points of each other. If either of those readings is less than 90%, it's an automatic fail. If the readings are one of them either below 95, or let's say we have a 95 and 100, and those are different, more than 3 percentage points difference, we consider that a failure, and then they go right to a rescreen within the next couple of hours. If we have 2 CCHD screening failures, the physician will order to follow up with an echocardiogram to really check out the structure and functionality of the infant's heart and identify whether there's any underlying congenital heart disease. This screening has the ability to pick up 95% of CCHD, critical congenital heart disease, in infants, most of the time before they are symptomatic. So it's a very non-invasive, easy, cost-effective way that we can pick up on what can be really serious defects really easily, really early on. Another screening that's completed is the PKU, phenylketonuria screening. So this PKU is an inborn error of metabolism, meaning the baby's body is unable to metabolize an amino acid, phenylalanine. So the baby will not screen positive for this, even if it has this disorder, if baby hasn't been fed and started to break down these amino acids. So we don't complete this again until after 24 hours of age, much like the CCHD screening. They have to have been fed either formula or breast milk, it doesn't matter, for at least the 24 hours, and then we do this screening. If this test was to come back positive, they would be repeat tested at 2 weeks to make sure it's a true positive. If it is positive, baby needs a special fed formula, or if mom is breastfeeding, there's a specific diet that she needs to follow, and we consider this a low phenylalanine diet. As long as this is followed up on and done correctly, then baby will be fine. If baby doesn't have a low phenylalanine diet, it leads to profound changes to the brain that lead to mental retardation. So again, not a very, very common problem, but can be a very serious problem. This is what the screening looks like. You might see this at the hospital. So this is a heel stick. Usually we warm the baby's heel to make sure blood flow is great to the area, and we're filling up the 5 little circles on that cardboard paper, and then that's sent to the lab. So you might have seen this being drawn in clinical, or see the results in the chart. So that's what that looks like. The last screening we're going to talk about is a hearing screen. So hearing impairment is actually the most common congenital abnormality for newborns. And it's been shown that the earlier detection and treatment is started, we prevent or reduce developmental delays. And if you can imagine, when a baby is a baby and brand new, we don't often know that they can hear or not hear adequately. So hearing screens are completed on all infants after birth. This is typically done by a staff member that is specially trained in hearing screenings. This is usually not completed by the nurse, but it is one of those screenings that the nurse is responsible for making sure this has happened prior to baby being discharged. So all infants are screened. If they pass, everybody's all good. We don't have to follow up any further. If they fail the first screening, we rescreen them about 8 to 12 hours later. And if they fail both screenings, we recommend that they follow up with audiology by the time they're 3 months. The Healthy People goal is actually that 100% of infants be screened at birth. They follow up with audiology by 3 months of age if they're a true failure, and then the baby will start interventions by 6 months of age. 6 months of age, and that shows the best outcome for reducing those developmental delays. This actually works really well if baby's asleep. The screener will come in and they put little speaker things over the baby's ears, and then ECG wires on the baby's head, and what they do is they emit those autoacoustic emissions, and then they read baby's acoustic brainstem response via those ECG readings to tell whether baby can hear that stimuli or not. A couple other different forms of testing that the RN is responsible for either completing or interpreting. So bilirubin, as we kind of talked about, babies that are high risk for jaundice because of that immature liver. So all babies are tested for total direct bilirubin counts at 24 hours, and that's via blood test. High risk or symptomatic babies are tested sooner than the 24 hours. So if they appear jaundice or we know that they're at a higher risk factor, we would test them sooner. So just kind of review that bilirubin has to be conjugated. Once it's conjugated, it can be put into the gut and excreted in the stool. But the longer that bilirubin sits in the gut, increases the chance of becoming deconjugated and reabsorbed into the blood system. And high bilirubin levels in the blood system can change brain tissue called kernicterus, which leads to lasting detrimental effects. So we test again at 24 hours. All babies are blood tested. We would test sooner if indicated. We can also test bilirubin via something called a transcutaneous bilirubin, or a TCB. This is a small little device that is used to press into the baby's chest. We actually do it right over the sternum. It emits a light through the skin. It takes 5 readings and then gives you a result of the baby's bilirubin level. This is a non-invasive, non-painful, doesn't require a blood test. We will use these a lot if baby's first blood test comes back like low, intermediate, or even sometimes if they're low risk but then look symptomatic, just to say, hey, here's a sorry, I got interrupted. Here's a non-invasive way to test baby's bilirubin. And then if it comes back high or concerning, we can confirm and follow up with a blood test. Either way that baby's bilirubin is drawn, we take the result and we find what risk zone it falls into by using a chart, and it plots on one axis baby's age in hours, and on the other axis the bilirubin reading. And then that tells us which risk category the baby falls into. And we use that risk to determine whether or not we need to notify the provider, and then what order setter algorithm needs started as far as phototherapy or force feedings or whatever the intervention may be related to that risk factor, and then how often we follow up. We're going to get practice using that chart here in a couple of weeks. We're going to do that as an activity. Blood glucose monitoring. So typically this does fall on the responsibility of the RN. We have specific policies for high-risk newborns that are at high risk for hypoglycemia. That includes large for gestational age, small for gestational age, and infants born to diabetic mothers. And then obviously any infant that is symptomatic of hypoglycemia, we would check. We always use the lateral portion of the heel to check the blood glucose. A hard level for blood glucose for infants is 40. We want it at least 40 or above, always, always. That number actually rises as the baby gets a little older in hours of age, but always, always 40 is a hard cutoff. The earlier that we identify hypoglycemia, the earlier we can intervene, which provides better outcomes for the newborn, which is why we have standard policies for infants that are high risk. Some different, this is the main procedure that we're going to talk about, circumcisions. So there are reasons that parents choose to have their child circumcised, and there are reasons that parents don't choose to have their child circumcised. It is completely parental decision. It does require consent. We do offer different kinds of pain relief. So the Sweeties is used for circumcision, as well as the lidocaine we talked about for that penile block. A lot of education is needed to the parents for care of the site afterwards, keeping it clean, what to expect, abnormal signs and symptoms that they would need to report, such as excess bleeding or signs of infection. One of the most important teaching points for parents is that as the skin grows back at the wound site, it looks white, sometimes a little yellow tinged. It's that granulation tissue that's recovering the surface of the skin. It is almost human nature to want to pick off anything on a wound. They see that and think, oh, that shouldn't be there. And we have to teach parents, don't scrub that off. That's the skin growing back. It's okay to be there. We show them how to cover the tip of the penis with Vaseline-lined gauze for the first 24 hours after the procedure to prevent the diaper from sticking to that tissue and pulling it off. Usually what I tell parents is right after the procedure, the first time you go to change baby's diaper, call me in, I'll walk through it with you. That way you can get another assessment on the site, and you can kind of gauge the education and training that you've provided the parents, assess their comfort level, knowing where they need further direction going forward. Lastly, we're going to talk about infant safety, which is very, very important for newborns. Preventing infection, making sure that hands are always washed, even more so in the era of COVID. Anybody that is handling the infant should have their hands thoroughly washed right beforehand. Proper identification of babies. Contrary to popular belief, a lot of babies look very similar. So it's very, very important to always be checking ID bands. If we take baby out of mom's room for any reason, that when we bring baby back, we are double checking mom's bands. It has happened in the past where babies are given back to the wrong parents. I know of one where mom actually breastfed a baby that wasn't her baby because the nurse didn't double check bands. So very, very important to ID baby. If we're transporting baby should always be transported in a crib or isolette. We're never, nurses are not picking up babies and walking down the hallway. Parents should not be walking down the hallway with babies. We take baby safety very, very seriously. Our back to sleep, ABCs, always alone on their back in the crib if baby is sleeping. Unless the parent is awake. We should not place the baby in bed with a mom who's under the influence of medications, anesthesia, or just too tired and falling asleep. This prevents smothering and infant falls. Babies can roll out of beds, and that can cause serious injury. Making sure parents feel comfortable and confident in using the bulb syringe. Babies have a lot of fluids and gunk that they work out of their system, especially in the first 24 hours. So making sure parents are comfortable with using that. And then signs and symptoms to report immediately. So if mom or dad or caregiver realizes that the baby has color changes, if they start to look blue, periods of apnea, all of those really serious signs and symptoms that we don't want them waiting until we come back around to do rounding. We want them calling us immediately. So those are some different infant safety points that we really prioritize for newborns. And that's it for today.